welcome to episode 156 of the Inside Knowledge podcast for people with IBS. I'm Anna Mapson. Today, I'm joined by Clare Bourne, who is a pelvic and digestive health physiotherapist. And we're going to chat a lot about the muscles that work together to help you have a poo. Clare has been working for many years in pelvic health physiotherapy. She started in the NHS and she now has her own private practice. Clare is also the author of Strong Foundations Why Pelvic Health Matters, which you can buy in bookshops. And it's all about pelvic health for women from childhood to menopause. She is very helpful and very clear in this episode and is going to give you loads of great insights into how working with someone on your physical health may really resolve some of your IBS issues. So I hope you enjoy this episode. To have you here. Maybe you could start off by telling everyone a little bit about yourself and your work, what you do.
Oh, yeah, absolutely. Well, thanks for having me first and foremost. So, I'm a physiotherapist, but my specialism is within sort of pelvic health. So bladders, bowels, sexual health. I treat women, men, children with anything across that spectrum. So that's what I do day to day. I'm also a mum of a couple of kiddies and I've written a couple of books on just like different topics around pelvic health. So just really passionate about like talking about these topics. And again, I think joining the dots, I think in clinic, we talk a lot about just like how the body's very connected. And even though we might be experiencing one thing, that doesn't mean that there aren't other things going on. So yeah, that's what I like to do on a day-to-day basis.
Great. Yes. And what sort of training and how would someone become pelvic health physio specialist? Because obviously the physio is quite general around the whole body.
Yeah. Do you know, every day in clinic, people are like, how did you get into this?
Why did you choose this?
Yeah. And I'm like, it's a long story. But yeah, I mean, basically, I did a normal physiotherapy degree. So I think most of us have that concept of physiotherapy being more like musculoskeletal, knees, hips, backs. But really, I mean, physiotherapy is such a diverse career, whether that be in a hospital. I've worked on intensive care, there's respiratory, there's pediatrics, but pelvic health really when I trained wasn't a massive thing. And actually when I graduated, it just happened to be my first rotation and my first exposure to physiotherapy. And I thought, wow, this is really, really interesting and very nitty gritty. And I kind of liked that about it. So I did other training just because we have to, but I've been in pelvic health more than I've not been in pelvic health for my career. So part of the training, I had the joy of working in the NHS for many, many years and having that sort of hands-on and supportive senior training through that process, working with amazing consultants. And then, I've done a lot of postgraduate training as well to sort of help with that. So I guess day to day, when people meet me, my job looks much more medical than it does physiotherapy these days. But it's that sort of beautiful combination of medical, physio, rehab, understanding conditions on a deeper level that is what actually appealed, I guess, to me about this area of physiotherapy rather than others that are maybe more traditional.
Yes, great. That's helpful because I think some people know a bit about pelvic health physiotherapy and others don't. And I guess for people who have IBS, there's, maybe everyone's symptoms are different, right? But there's either like predominantly constipated, slow transit time, nothing's moving, or they have diarrhea, leakage, incontinence issues. So maybe you can say a little bit about how what you do supports all of those symptoms.
Yeah, no, absolutely. I think you're absolutely right. And I think now pelvic health has grown in awareness, but a lot of people are like, well, if I haven't had children, how do you help me? And I'm like, oh, goodness me, like the majority of my caseload actually now would not really be necessarily new mothers. So I have the privilege of actually working in a bowel team. So not all of us would work with those who have bowel symptoms, but some of us have done additional training to do that. So you're absolutely right in the sense of, I guess the baseline is that your pelvic floor muscles are responsible for keeping poo in when you want it in, but also letting it out when you want it out. So yes, the digestive system is complex in the sense of it comes from our mouth and it goes all the way to our bottom. And digestive health or gastro issues can be anywhere down that tract. But a big part of that is that process of in or out. And I think the thing is, we actually learn this very, very young as children when we potty train. But no one actually has the concept of that control mechanism is actually a muscle like a bicep or a tricep that's actually in our control. The external anal sphincter and your pelvic floor are something that we can choose to contract and relax. Now, a lot of it is subconscious through, learning to go to the potty when you feel an urge and then relaxing and letting it out. But it's amazing how much through life that mechanism can be confused. So, I guess that's where I can work with children, men and women, because we all poo. So it's not about gender, it's not about you've had a baby or not had a baby. It's just that this is a mechanism that needs to be supported sometimes. So, as you say, the topic of IBS is huge. And, what is IBS? What does that mean for different people? Also, I think, what does constipation mean for people? Because I actually always ask that when people say, I've always had constipation, I'm like, tell me how that's looked for you. Because actually, what I might interpret as constipation, or you might interpret as constipation, might mean something completely different to the individual. But I guess what I think about within the pelvic floor stuff, obviously you mentioned there the transits, that's how it's like moving around the gut. And really doing a poo is this combination, obviously, of what's going in, how your digestive system's then dealing with it and moving it along, and then the evacuatory element of then how can it come out. Now, if something's not working at that end, it can then knock things on up higher up the chain. So it's very much understanding that full picture. Obviously our mind, the psychology, the gut brain axis, all having an influence within that as well. But yeah, I guess my specialism is to assess the muscles, work out what's the main issue, because having diarrhea or no control is very different to having maybe what you'd call constipation or struggling to get a poo out. And those mechanisms are completely different, and our treatment would be different. So that's our job, to come in and sort of support with that.
Yeah. And how do you assess people? Like, is it, obviously you're talking to them, asking them questions, but you're doing some sort of physical, is it called biofeedback, where you're like getting a sense of which muscles are clenching and opening and that sort of thing?
Absolutely. Yeah. So, our initial assessment would actually be us examining the person. So depending on their journey to coming to us and what their history is, and obviously what gender they are and what age they are, the assessment looks different. But if we talk about adults, for example, now, generally speaking, we love to see people in person so we can physically examine. I would say, however, I have treated people virtually where I've never even touched them, and they have also got better. So I think it's challenging that narrative of, does everything always have to be in person? Not necessarily. Does it help us fully understand the picture? Absolutely, yes, generally. But I always want people to know that actually sometimes reaching out to see someone in person or coming for an examination can feel really scary. And actually a first step or virtual consults can also be a nice step into that. Because what I always say, the basis of any physiotherapy is actually you understanding your body better. And we can do that through education as well as hands-on treatment. Like, I think long gone are the days, or we're definitely moving away from the concept of physiotherapy being like, you come to me, I fix you, you leave my room, job done. It's very much like we're a collaborative team to support you in your body. So longer term, this is a change. So examination wise, obviously, when we're dealing with the bowel, we generally are doing an anorectal examination. So what we're then feeling for is, again, like, what's the muscle tone like? So tone being like how switched on a muscle is. So some people have low tone, where actually there's not a lot of activity in that muscle anymore. Or some people might be very switched on all the time and actually really struggle to let go. So those are things we're looking for. We're then looking at what's your ability to control that muscle and what's happening when you try and think about pooing. So we start with all of that so we actually understand. And obviously then if someone else has also got pain with intercourse or erectile dysfunction or something else, and again, we need to understand that in the context of how their muscles are behaving, because your muscles around your bottom are connected to the muscles around the rest of your pelvis, and therefore it's just understanding the whole picture. Then yes, we may use different forms of biofeedback. So biofeedback is quite a broad term for giving feedback to an individual's biology. So obviously when these are muscles that you can't see, like most of us can't see our anus day to day, it can be really hard to connect with. Very different to an arm where you're like, oh, I can see it moving. How lovely. We rely a lot on feel. And so biofeedback is a way of basically giving more feedback into the neurology system, brain, through our eyes, through seeing. So in my clinic, we may use EMG. So this might be a probe that we would use to show you muscle activity. I use ultrasound. So this is not for diagnostic purposes, it's for feedback. So you can see what your muscles are doing. Touch is another form of feedback. For some people, the use of balloon biofeedback might be appropriate. So there's a really huge range of what that could look like. And sometimes that might mean using bits at home, it might be doing bits in clinic. It's always going to be a collaborative approach, but the assessment is key, and then the steps alongside medical management, often all together, is what gives us kind of, I guess, the greatest success of improving symptoms.
Yeah. And that feedback, I guess, is really one of the things that sometimes goes a little bit, isn't it, in IBS? Like people are ignoring the urge to go, or trying to sort of minimize uncomfortable symptoms. So almost trying to break this gut-brain connection, because what's happening down there is really not what you want to feel. And so what I find is people, trying to avoid feeling hungry because eating hurts, or trying to avoid going to the toilet because it's a bit uncomfortable. And so maybe forcing that loss of connection.
Yeah, absolutely. And I think that's why it's so important to really understand for the individual, what is the main symptom that we're struggling with? Because for some people, it might be, as you say, like I have patients with IBS who come and they're like, I hold on because I'm so anxious. It might sound really loud, or I'm really nervous to poo in a house with somebody else now because, you know, I can get really explosive diarrhea, and therefore I've got into this pattern of holding, which has created a whole another load of things going on. Or it might be like, I go, but I just never feel like it's complete. And then that's really stressful. I'm going multiple times a day. So I think that's it. You know, when we hear these terms, it's very easy as like healthcare professionals to be like, oh, that must mean this, or this must be. But actually, what is the most bothersome thing for that individual? And then how do we support them to improve that? And that might have a knock-on effect to other positive things. But yeah, some people are like, you know what, that bit doesn't bother me. It's this bit that bothers me. And therefore, that's why we need to individualize that treatment. And why I always say to people when they come in, when they're like, how many sessions am I going to have? And what are we going to do? And I'm like, I actually don't know yet, because each session we will evolve and work out. And my job is there to be a detective and help you as we journey on this. And sometimes the only way you know that is you go through it. So there isn't like a one formula that we kind of like fit everyone into. It's very much like, how do we support you on what you're experiencing?
Okay. And actually just touched on there about sort of actually going to the toilet and sitting on the toilet. Like, I know there's, people might have heard about having a squatty potty or putting their feet up, or like trying to get comfortable. Like, do you have tips for physically letting the poo out? Like, how should people position themselves or approach going for a poo?
Yeah. I mean, I believe like the biggest principles are that you actually need your body to feel relaxed. That's, above everything, and I think this a lot with children, when we put them on a big toilet and they're like holding on, like none of them looks relaxed. Now, how do your pelvic floor muscles to let go and release to let a poo out if actually there's body tension everywhere else? And essentially your pelvic floor is part of what we would label very broadly the core. Now, when you're basically holding yourself up by your arms, your core muscles are very active. So I think what I always say to people is, whether you use a stool or don't use a stool, we're all different heights. We all have different toilets. For some people, using a stool is a game changer. But it's really important, I think, we don't have sweeping statements of like everybody needs a stool, because some people put themselves in that position, and maybe for different dysfunctional reasons as to what's going on with their digestive tract, it's not the right thing for them. So I always say the main thing is that you have like planted feet, that you almost feel grounded on the floor, that you can really actively think about relaxing your body. It's amazing how, because our lives are so fast paced, or we're therefore doing emails and everything is just like, I'm like, you actually just need to check in with how your body's feeling. Like, are you just sat there holding your breath? Are you holding in your tummy? A lot of us will not connect with the concept of holding in our pelvic floor. Like, it's just not something that we've probably connected with. But I'm like, if the rest of you is very switched on and held, the chances are your pelvic floor is behaving in a similar way. So just that concept of sort of grounding, maybe leaning forwards onto your arms, letting your stomach relax, being a bit present with what your body actually needs to do, and not like, 20 other places that you're going to be later on today, are just really basic principles to kind of allow yourself. We could go into the nitty gritty of it all, but in essence, what needs to occur to let a poo out is that your anal sphincter, which is a ring of muscle, needs to relax along with your pelvic floor, and one of them sort of slings around the bowel to keep it into a kink so poo stays in when we want it to stay in. But then it needs sort of relax to allow it to be a bit more as a slide to allow a poo out. It's essentially a process of relaxation, and therefore understanding the neurology of the system as well as your physiology of your muscles to relax is essentially what needs to happen. I mean, we all know that if we go on holiday and we feel a bit stressed, it's quite hard to relax to do a poo. Or, you know, you might be about to start and the doorbell goes, and it's amazing how quickly that poo urge might go away. Now, that's because your body's like, oh, can't go now, must stop it because I need to go and do another task. So if your body's always in this task orientated thing, I talk a lot about this with people in the morning where they're like, oh, I'm on my emails from 7 and then I don't know why I don't poo, and I'm out the house by 7:30 and I've not eaten and I've not drunk anything. And I'm like, well, it's because your body doesn't actually feel it's got any space or time to tell you what's going on. So again, I think it's that sort of, yes, sitting on the toilet is very important, but what else resembles needs to happen to allow that sort of process to occur is also key.
Yeah. And I actually also maybe it's not scrolling. Like, I think that's key. People take their phone into the toilet now. I think there was some research last year that said people who scroll on the toilet like have got a bigger chance of getting hemorrhoids. Just sitting for longer than you need to, just because you kind of get engrossed in Instagram or something.
I mean, we've all been there. We've all done it. You know, that's the thing. Like it's a very sort of becomes such a normal part. But I actually have to sometimes challenge my patients and I'm like, I need you to tell me. And they're there doing like crosswords or, you know, things for like an hour. And I'm like, you know, your bottom wasn't designed to sit on a toilet for an hour. So that might be part of our problem here. But I think what's so interesting as well, and I don't know if you see this with your clients, but so many habits come through in life that because we don't often talk to people about doing a poo, we have no concept that that's not normal. And if our parents do it, then we will do it because that's what we've been shown, or we might have always been told you have to go for a poo in the morning, and not always associated that doing a poo, an urge is an important part of doing a poo. So then you're just told that, you know, at 10 o'clock is poo time, but that may not be your natural rhythm of your body. So I think, it's
get any urge. Like if they rarely feel an urge to go.
So some people.
Should they create a kind of routine by kind of going at 10 o'clock? If you never get an urge and you just like rarely going for a poo, should you try and create that sort of routine?
Yeah, I mean, it definitely can be something that we will work on with people as a wider picture for sure. Because again, I would say, let's understand in the digestive tract. So essentially when we eat and drink, it stimulates the tract from the top, and then that can help to stimulate throughout the digestive tract. So there's a chance, you know, especially with kids that struggle with this sort of stuff, sometimes we'll encourage parents, you know, 15, 20 minutes after eating, it might just be worth having a sit on the potty or sit on the toilet and not be sitting there for an hour, but just start to see within that process of relaxation, is there any element of sort of trying to retrain that process? Yes, absolutely. I wouldn't use it as an exclusive management, but definitely as part of it, because you're then more likely, as you say, like some people are so almost like disconnected from that area, or it's become, you know, a lot of people end up in my clinic have had symptoms for 15 years plus. Now that has become a traumatic, very difficult experience that therefore, of course, in order just to survive life, and I'm sure you see this with your clients, we have to build strategies as humans to survive. Now, sometimes those strategies will serve us for a short while, or they might serve us longer term, but sometimes they actually become more of a problem. And that's something that we then need to unpick. But we're only going to unpick that once we give you other strategies to make you feel more supported.
Yeah. And what about if people are in the same way, like they only go once or twice a week, but it's always big and painful? Like, are there any sort of techniques for, you know, lessening the fear, but also like physically as this large poo comes out, for not making it hurt as much? Obviously, there's, you know, the dietary stuff, which I talk about, people, fiber and hydration and so on, but like a physical sort of thing that people could think about.
Yeah, I mean, I think again, it's so complex as to why is that occurring. I think, you know, ultimately, you're just taking a step back, you can almost overstretch your rectum, so your rectum actually becomes bigger. So the reason you've got this big poo, but you're not feeling it until there's a big poo, is because actually the bowel has stretched, and in order to therefore get the same signals that someone else might get, it has to be so stretched in order for your brain to kind of get that. So I would argue with someone like that, potentially alongside all the dietary stuff, we need to think about a bit of medication stuff to see if we can help the bowel to start moving. That doesn't mean necessarily stimulant laxatives or anything like this, is where it's like it needs that wider medical management. But we probably need to somehow soften that stool help the bowel to be going more regularly to sort of stop this constant stretch and pain. The reality is, if every poo is painful, imagine what your body tries to do when it's in pain. It tries to stop the pain. Like, it's not, as humans, we are designed and wired to stop ourselves experiencing pain, right? You touch something hot, there's a reflex to take it away. There's a lot of reflexive activity in the body. And we see this sort of vaginally as well with people who maybe have pain with intercourse or pain with smear tests. You know, your body becomes wired to protect you from that experience. So we can see the same within the anus and the pelvic floor as well. So if every poo is painful, your body's going to try and stop you pooing because it is like, I don't want to be in pain. So I think I would say, like, we need to understand, why is it painful? Like, is it fissures? Is it hemorrhoids? Do we need to be treating that? Do we need to be softening the stool and then helping that process? Because it's very hard to change a muscle's behavior if pain is a major driver. But I mean, I'd say there's always the basic principles of, you know, not ignoring urge. Routine can help. Making sure we're like gradually eating and drinking, as you say, all the nutritional fibery stuff. But sometimes it's that we actually do need a bit of medicine to get us through to then change that behavior over time. You know, some people in our clinics, if they've got a lot of pain or a similar picture, potentially benefit for some Botox. Now, I know people say, like, isn't that what you put in your face so you don't age? I mean, yeah, can be great, absolutely. But actually, Botox really came, I mean, it's been used in medicine for years within, you know, children with neurological things like cerebral palsy to deal with spasticity within legs. So their feet are flatter and they can walk better. It can be used within the pelvic floor for pelvic floor muscles that over time have become so active because of pain or other reasons, to help, again, allow us this window of opportunity to empty the bowel better, to reduce that pain. So I think what I would say to people is there's so many options. It's often this beautiful combination of, and the team I work in, it's this medical, physiotherapy, nutritional management that needs, and psychological, to be totally honest with you, that needs to come together for actual resolution of symptoms.
Amazing. And what about with people who have maybe looser stools and often are forcing themselves to go when they don't have an urge because they want to kind of clear out or get something out before leaving the house? Because that's another pattern that I see quite a lot. People who are like forcing it every time they need to go.
Yeah, bless them. Yeah, I mean, what I would say is, you know, a big part of being able to empty the bowel well is stool consistency. So you're absolutely right. Looser stools, you can almost feel like, oh, I've not emptied. You're either having like diarrhea where you feel like all you've done is empty your entire body contents, or if it's this sort of more softer, but it's then harder, especially in women who maybe have also got like a slight pelvic organ prolapse related to their bowel, sometimes called a rectocele, sometimes called a posterior wall prolapse. Obviously, there are other types of prolapse as well that can occur within the bowel, so rectal prolapse, or what we call interceptions, which are higher up the tract. So what I would say is, I mean, predominantly we need to try and understand, why have you got the diarrhea? Again, I know there's a lot of work that you will do on like, how can we create that stool consistency to be better? For a lot of women in my clinic, we may also look at things like rectal irrigation. So if you've gone and you're thinking, I really want to make sure I'm completely out, we can use water using a variety of devices to help flush and clear the rectal area or even higher up, depending on the type of kit that we use, to give that individual confidence as they go out that they're not going to have to go again, or they're not going to have an accident. Now, that then needs to be sandwiched with a longer term approach of, are you not able to control because your muscles are weaker? And that's also, you know, eroded your confidence. And do we need to help you if you have got some muscle weakness to build up that strength? So, you know, even if you were to have another urge as you go out, that you've got control of this and you've got your muscles. So again, a very collaborative approach. You know, I always say to people, try not to force excessively, because it's that sort of thing of, again, we're sort of trying to do with one strategy to help, but we might then cause other problems. It's better to kind of take a step back and be like, right, how can we actually deal with the issues here? What other strategies can we give you to help reduce that anxiety and fear? Because it is totally normal to be worried about pooing yourself when you're out of the house. That is a very normal human fear. So that's not wrong, and you're developing strategies to help with that. But what other things could we bring in that might actually be more helpful for you in the short term, whilst we also help you manage and improve this longer term?
Yeah. And can it sort of damage your muscles to be forcing them and trying for straining, even if there's nothing there. There's, people maybe straining with a big harder poo trying to get it out, but if they're empty and it's just loose poo there, can that also lead to issues with your bowel longer term?
Yeah, definitely. I mean, chronic constipation, and again, I think that's where the constipation term has to be sort of used lightly because it will mean different things for different people, but chronic straining, forcing down onto the pelvic floor, as well as the pelvic organs, is one of the risks for pelvic organ prolapse, pelvic floor weakening, and therefore a cascade of other symptoms as well. So sometimes, yes, to initiate a bowel movement, a gentle little bit of pressure may be required. And I think this is where then differentiating between a gentle push and an excessive straining, they are different. So I think I would always encourage women, if the only way you can open your bowels is by sitting and literally forcing heavily for a long, long time, that is a form of dysfunction that we want to support you with to help understand why that's occurring. So hopefully stop the sort of domino effect, as I say, of one problem becoming another problem, becoming another problem.
Yeah. And is it sort of similar? So you mentioned you work with the bladder as well. So often people are, will say they have an overactive bladder alongside IBS. It can be quite similar type of symptoms. So they're literally just running to the toilet for one reason or another all day. Is it similar sort of process that people would go through for bladder issues?
Yeah, absolutely. We do see a really close relationship between bladder and bowel issues, particularly sort of more constipation, because though all of our medical diagrams make it look like your organs are completely separate, like they live in different villages, they actually just sit on top of each other within the pelvis. The pelvic area is really not that big. So if we have got a bowel that's maybe struggling to empty, that sits heavily on the bladder, that can actually make you feel like you're constantly needing a wee, even if actually the pressure's not coming from inside the bladder, it's more from outside the bladder. Similar things, like if a woman's got fibroids, again, it's that can also be causing havoc within this whole system. But yes, there's definitely a close link. Management wise, again, it's understanding kind of, there can be a lot of like, oh, it's just pelvic floor exercises. I'm like, no. We need to understand the bladder's behavior, why it's behaving in that way. Have you started going more? Because again, you're worried about wetting yourself. Well, again, normal. It's a great strategy. You're worried you're going to wet yourself because you haven't got as much control. What do? You go more. But then going more creates other problems. But there's no point in me telling you to just go less if you have no confidence you can hold better. So then that might come back to muscle training and then changing bladder behavior. Sometimes medication, again, is helpful to just calm that bladder activity down. But again, if no one's asked you about your bowels, and actually there's a real problem with your bowels, we always say treat bowels first, normalize, regulate, see the impact on bladder, and then treat bladder. I say in my clinic, majority of people have a little bit of everything. So yeah. it is this kind of, and again, seeing like, ooh, where did this all begin? It's amazing how much starts at childhood. And I don't know how much you see that with those that you work with, but when you actually track it back, they're like, well, yeah, I remember this at school, or toileting habits starting at school, either through restriction because schools not let you go, or to manage it. Again, you're worried you won't be able to go in lessons, so you go more in all the breaks, even if you didn't need an urge. So yeah, tracking it back, trying to understand the origin as much as we can. And we don't always know why. We don't. That's the reality. But we do as much as we can to sort of really unpick things and then, change behavior longer term.
And what about perimenopause? Because there's a lot happening with the pelvic floor throughout hormones. So when we've got all these hormones fluctuating, jumping about, do you see a lot of people coming at that stage in life as well?
Yeah, definitely. Absolutely. I mean, I think from a gut perspective, from a like hormone estrogen impact on the gut, that can definitely impact, and progesterone as well. Things all going haywire, up, down, or low, can lead to a bit more change in transit. From a pelvic floor perspective, again, I think we hear a lot of like, oh, well, just dropping estrogen makes your pelvic floor weak. It's not quite the correct narrative. Actually, what's occurring is that, yes, if you just look at skeletal muscle within the body, it weakens as we age. This is a process called sarcopenia, and it happens to us all. Depressingly, it really drops post 35. Yay. Which means we have to work at building muscle harder than we did before. And the pelvic floor is no different to that. So there is definitely an element of muscle weakening that's occurring. Is it estrogen or is it just aging? Maybe a collaboration of both, but it's definitely just an aging process. Alongside that, in the female body, then yes, the vulval, vaginal, anal areas, they have a lot of estrogen receptors. So again, when that estrogen does decline, decline, it has an impact on thinning those tissues. So pelvic organ prolapse becoming more of a symptomatic thing, even if it was there before. Bladder and bowel symptoms becoming more symptomatic. So yes, I'd say across the spectrum, perimenopause can absolutely be, it gets a lot of the blame. What I would say, it's more like the straw that broke the camel's back. It didn't cause all the problems. But for example, maybe a woman that's had an injury to her anal sphincter through childbirth and has got away and been fine, then perimenopause comes, and because that hormone shift has occurred, it sort of, I guess, unearths a weakness that was always a bit there, but the hormones were masking it. So yeah, it's definitely something we see a lot of, and then that's when maybe some vaginal estrogen or estrogen in the area is really beneficial to help with that side of things, whilst we're also working on building muscle or control or a changing muscle behavior and things like that.
Yeah. Okay. Brilliant. Right. Well, that's, amazing. So helpful. I think we've covered a lot, but there's some really good things, sort of suggestions in there for people. And I hope that opens it up to people to explore a bit more about the physical side of having a poo and the digestive side, because it's not just around, diet and even the gut-brain connection. There's some actual like physical things that, some are under our control and some are not, but be really great if people would, know a bit more about it and explore it. What do you, is there anything sort of we haven't covered that you think would be helpful to just let people know about pelvic health physiotherapy for digestive conditions?
Yeah, I mean, I'd say my biggest message is that it's not all about Kegels and pelvic floor exercises.
Yeah.
Pelvic health is far more complex. And actually, if you are struggling, it's about finding the right person who's trained in that sort of field to really help you take a step back. And I think what I always say about the privilege of being a physiotherapist is that we often have time. We often have the time to sit with you. We get a bit longer. We're, I hate the term really, but holistic. We're really looking at this whole side of things. And so, I guess it's that there is a thing. It's a thing we can help you. We may not have all the fix, but what I would say is that the majority of people they've journeyed with their bowels for so long. They know there isn't one fix, but what they want to understand is how it's all connected, because I think it's that lack of connection. And I'm sure you see this where they might have seen one doctor and told, you've got IBS, just do this. Or they've seen a nutritionist, they're like, oh, now you need to do all of these things. And I think having that sit down pause just to be like, it's probably a bit of everything. And we probably just need to understand that in your life as well, that I find brings the biggest difference.
Yeah. And can people get referred through their GP to see somebody on the NHS?
Absolutely, yeah. So, I mean, as I say, I worked in the NHS for years and years, and yes, we accept. So what I would say, the tricky thing is it just really depends on local commissioning. So, some pelvic health physio teams have really good links with colorectal doctors and gastro doctors, and others, it won't really be part of their remit, so they may not be trained in it. We do have specialist centres. So, for example, London has a very good bowel hospital where lots of people can get referred as a tertiary centre. So that means that it's not necessarily your local hospital, but for your specialist conditions, it can be. And there are obviously other ones around the country. But it's definitely worth a conversation to ask. They may, not all GPs have even heard about us yet. We've still got a lot of work to do to try and support that, which we're trying. But, there's definitely NHS support out there if you're looking for that guidance.
And where can people find you and follow you? You said you've written some books, maybe.
Yeah, I mean, so I think the main one that would be really helpful for anyone suffering with bowel conditions is my book called Strong Foundations, Why Pelvic Health Matters. It's actually just a kind of a journeying book from childhood through to perimenopause. It's designed for females and there's a lot about bowel health and how that links through life and how the other stages of life feed in. So it's really like a kind of looking at pelvic health through life. I work, as I say, clinically in London within a bowel team. So if anyone would be looking for that sort of support privately or through insurance, then that's something that I definitely provide. Also got lots of information on my website where I just try and kind of open up the conversation about these things, or social media. So kind of reach out, shout, do your own journey, but just know that there is help, and actually the awareness of that we help in this area is still very much not known of.
Thank you so much, Claire. Thank you.
Thanks for having me.
It was a great episode. Thank you so much to Claire for your time in recording that session. Really recommend you go and check out her website. I put all the link in the show notes, but clare-bourne.com, or on social media she's Clare Bourne Physio. So you can go and look there and contact her if you're in the UK, obviously, about working with her, if you are in London or if you are close to London and available to travel. So yeah, really recommend you check out her book, her website, and follow her on Instagram. Such a helpful episode. Thank you. All right. Thank you for listening to this episode of The Inside Knowledge. Better digestion for everyone.